Hello and welcome, everybody. My name is Matt Shepard. I'll be moderating today's session, Medicare Open Enrollment Period Updates for 2025, presented in partnership with the Michael J. Fox Foundation for Parkinson's Research. Our presenters today are Center for Medicare Advocacy Co-Director David Lipschutz and Senior Medicare Advocate Melanie Lambert, with special guests from the Michael J. Fox Foundation, Senior Federal Government Relations Manager Mason Zeagler, and Patient Council Member Maria De Leon. Before we hear more about these great organizations, please bear with me. I'll do a little housekeeping. As with all online presentations, our audio and video connectivity are going to be at the whim of your internet connection. But it can really help if you make sure you have the correct microphone and speakers set in the audio controls, which you should see at the lower left of your Zoom screen. Should you have trouble watching or listening throughout the presentation, all registrants will receive a link to the recorded presentation and today's slides again in a follow-up email. The recording will also be posted by the Michael J. Fox Foundation on their website. On the topic of audio, should you need it, closed captioning is available and can be enabled with the CC button at the bottom of your screen. We have an absolutely incredible turnout today. We had over 2,500 registrants from all 50 states sign up today. So we are going to be crushed for questions, I am sure. Please don't be upset should we not get to your question. But on the topic of questions, note that in addition to the regular chat feature, Zoom has a questions button. You can open that up and actually type questions right in that panel. I'll be monitoring those, and we'll have Jeff Wiseman from the Center and Brenna Callahan from the Michael J. Fox Foundation monitoring our chat. Thank you both for that. In that chat, you can find yet another link to today's slides, and we welcome you to say hello, let us know what state you're from, and your organization, if any. You might hear from other members of our various organizations while you're in there. A last note on questions and interaction. We also got hundreds of questions and comments during the registration process, and we thank you for those. Fantastic work. And we will try to address common themes from those as well. In fact, we may repeat some of those points that we really want to hit and get home. Speaking of our presenters now, a little bit more about the organizations they represent. The Center for Medicare Advocacy is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities by providing exceptional legal analysis, education, and advocacy, all based on the experiences of the real people who contact the center every day. And now I'll introduce Mason Zeagler, Senior Federal Government Relations Manager for the Michael J. Fox Foundation, to tell us a little bit more about the foundation himself and to introduce Patient Council Member Maria De Leon. Mason.
Awesome. Thank you, Matt. And hello, everyone. My name is Mason Zeagler, and I am a member of the Michael J. Fox Foundation for Parkinson's Research Public Policy Team. The Michael J. Fox Foundation for Parkinson's Research is a nonprofit dedicated to finding a cure for Parkinson's disease through an aggressively funded research agenda and to ensuring the development of improved therapies for those living with Parkinson's today. MJFF was founded in the year 2000 by actor and advocate Michael J. Fox, who was diagnosed with Parkinson's disease at age 29. As a member of the public policy team, I focus on how our community can leverage government policy to increase Parkinson's research investments and improve patient access to care necessary to diagnose and treat Parkinson's. Parkinson's is the fastest growing and second most common neurodegenerative disease worldwide. And in the United States, more than 1 million people live with the disease. And research shows that about 90% of people living with Parkinson's rely on Medicare for their health coverage, which is why we've partnered with the Center for Medicare Advocacy to bring you this webinar today. This year, it's particularly important to make sure folks living with Parkinson's disease and their loved ones understand the changes coming to the Medicare prescription drug program known as Part D. In particular, the new out-of-pocket spending cap and option to spread prescription drug payments over a planned year, which David will cover in detail, are changes to the program that could provide significant relief to people living with Parkinson's as well as other chronic conditions. We extend a big thank you to CMA for allowing us to collaborate on this event, and our hope is that the tips, guidance, and resources we share today will help folks who are seeking direction, clear next steps or assistance as they enroll in Medicare or help others enroll. Now, I want to introduce Dr. Maria De Leon, a fellowship-trained movement disorder specialist and an avid research and policy advocate. She was diagnosed with young onset Parkinson's disease, or YOPD, in 2008, and with lupus a few years later. She serves on the Michael J. Fox Foundation's Patient Council and previously served on the Parkinson's Foundation's People with Parkinson's Advisory Committee. Dr. De Leon received her BA from the University of Pennsylvania and her MD from the Hahnemann Medical School. Thank you for joining us, Maria.
Thank you so much, Mason. Hello, everyone. Thank you for joining us this afternoon. I appreciate the opportunity to share my perspectives with you today. My goal is to highlight important considerations for people living with this disease and their loved ones, which Mason and I will discuss later on in greater detail. But for now, I would like to pass it back to the CMA. Thank you so much.
All righty, we'll pull David Lipschutz up to get our presentation rolling in earnest. David.
Great. Thank you, Matt, Melanie, Mason, and Maria, and apologies for also not having a first name that begins with M. More importantly, thank all of you for attending today. This is a quick agenda of what we're going to cover over the next hour and a half you will be spending with us. I'm going to kick us off with a quick overview of the Medicare program and the upcoming annual election period, and talk a little bit specifically about Medigap plans and Part D plans. I'm then going to move on to discussing various trade-offs between the two major coverage types in Medicare, Medicare Advantage and traditional Medicare. Then Melanie will step in and provide some practical advice concerning choosing coverage options and navigating this Medicare maze. She'll then cover various types of assistance that might be available for beneficiaries, and then I will step back in and go over some of the changes for 2025, including what we know so far about general changes to Medicare Advantage and Part D plan offerings, as well as Part D changes such as the $2,000 out-of-pocket cap and new program that allows drug costs to be spread across the calendar year. Then Mason and Maria we'll talk a bit about important considerations for people with Parkinson's and other chronic conditions, and we'll then kick off a discussion and Q&A in the remaining time. Note that we have included far more information in the slides than we will have time to give complete attention to. We will touch on the main points, however, but leave the rest for your reference, and a number of these slides include links to further information about much of what we will talk about. As Matt said, we will repeat some things, say some things in different ways, but we'll be unable to get to other things. So buckle up and enjoy. First, an overview of the Medicare Annual Enrollment Period. Let's begin with a quick overview of the Medicare program, which covers 67 million older adults and individuals with disabilities. Medicare is divided into 4 parts, parts A, B, C, and D. A and B form the core of the Medicare program and together comprise what's known as original Medicare, also known as traditional Medicare, sometimes referred to as fee-for-service. It is the default in the Medicare program. As we'll discuss more on the next slide, most people with Medicare have Medicare plus something else, some other type of coverage that supplements their Medicare, or in the case of Medicare Advantage, replaces it. Part C, Medicare Advantage, is the private plan option in the Medicare program. People enrolled in Medicare Advantage get their care through that Medicare Advantage plan. The program has grown rapidly in the last 15 to 20 years, and now Medicare Advantage enrolls more than half of all Medicare enrollees, beneficiaries. Part D is the prescription drug benefit that began in 2006. It is only available through private plans, either standalone prescription drug plans or PDPs for those in traditional original Medicare. And it is also available through most Medicare Advantage plans, Medicare Advantage prescription drug plans or MAPDs. Medicare is not free, nor is it comprehensive in coverage. Most people don't pay a premium for Part A, but most people do pay a premium for Part B, about $175 a month this year in 2024. While lower income individuals can have assistance paying for this, as Melanie will touch on later, higher income individuals can pay more for their Part B and their Part D premiums. Medicare Advantage premiums vary. Many are zero, Part D premiums vary as well. And note that we don't yet have the 2025 figures for Parts A and B premiums and cost sharing amounts. We expect those to be available soon. Our patchwork health insurance system in this country is overly complex, confusing, convoluted, and complicated. In many ways, it does not make sense and is jury-rigged with duct tape and rubber cement. And while many of us are working to change it, this is what we have today and the rules we must operate under. This slide alone can fill an hour presentation, but we will dispatch with it today rather quickly. Most people with Medicare, Parts A and B, also have something else. Nearly 90% of Medicare beneficiaries have some other type of coverage that either coordinates or doesn't with Medicare and fills in some of the gaps or doesn't fill in the gaps with Medicare. Only about 11% or 3 million people don't have anything in addition to traditional Medicare. These different insurance types have different rules for how they interact with Medicare coverage, if at all, including when you can pick it up or drop it. The general rule is that Medicare is primary to other insurance. When it comes to employer-based coverage, there are rules that dictate when employer plans can be primary to Medicare coverage. That relies on the size of the employer, as well as whether or not someone has their employer-based insurance through current active employment. Once someone retires or goes on COBRA and is no longer actively working, even though your insurance might look the same, everything changes in the eyes of Medicare. So a quick takeaway: pay attention when your coverage changes due to, or when you retire or stop working or don't have coverage based on someone's current active employment. We're going to talk a little bit more about Medigap plans in a few moments. Military coverage, Veterans Administration coverage works independently of Medicare, whereas TRICARE for Life supplements Medicare. The Medicaid program is a blended state and federal program for people who meet categorical eligibility requirements, things like they are either 65 and over or under 65 with disabilities, as well as meeting certain income and asset requirements. People can have both full Medicare and Medicaid. There's also a program that is offered through Medicaid called the Medicare Savings Programs that can help pay for some of Medicare expenses. Melanie will touch on those later. As noted, Medicare Advantage is a way to supplement Medicare, but it actually really replaces your Medicare as long as you are enrolled in that plan. And the Part D prescription drug benefit also has a program available for individuals who qualify due to income called the Low Income Subsidy or Extra Help Program. Melanie will also discuss this more later. So if that was all not confusing enough, there are different enrollment periods that apply for the different parts of Medicare. There are times during which you can enroll or make changes to your coverage. And first, we'll talk about briefly Parts A and B, and then move on to Parts C and D. When someone is first eligible for Medicare, there's a time period within which they can enroll. People often get Part A automatically and have to actively enroll in Part B. If people miss that initial opportunity and aren't otherwise entitled to a special enrollment period, there's a general designated time period to pick up Parts A or B during the general enrollment period, the first 3 months of the calendar year. Note that there are special enrollment period opportunities that are usually tied to someone's employment. For example, when someone has employer-based insurance of the right employer size and they're currently actively working and have the insurance as a result of such work, then they might be eligible for a special enrollment period. These have expanded in recent years. The takeaway message is, when approaching Medicare eligibility, do your homework. Take stock of what you already have, what you might be entitled to, and don't put off important decisions. Some people can delay enrollment in Part B of Medicare without penalty only in certain circumstances when their employer coverage is primary to Medicare. There are also enrollment periods applicable to Medicare Advantage and Part D plans when initially eligible for Medicare. For Part D, someone needs to have either A or B in order to trigger eligibility for the Part D prescription drug benefit. For Medicare Advantage, someone has to have both Parts A and B in order to trigger eligibility for Medicare Advantage. Highlighted in red on this slide is the reason that we are all gathered here today. The annual enrollment period that starts next Tuesday on October 15th, about which we'll talk more in the next slide. We will also touch on a more limited enrollment period that begins in January that's only really applicable to people in Medicare Advantage plans. And also note that it's similar to Part A and B, there are a number of special enrollment period opportunities available with respect to Medicare Advantage and Part D plans when certain triggering events occur. This link will take you to a document that includes them all. Tuck this away in case you run into a situation where you really need to get out of your plan mid-year. Break glass in case of emergency, or simply learn all these special enrollment periods to impress your friends. The advice provided in this webinar regarding coverage choices generally applies to people who are first eligible for Medicare and trying to decide what coverage they want, as well as choices that people make during this annual election period. So, as the leaves are turning, baseball begins to wind down, and football ramps up, we approach the annual rite of passage known as the annual election period, sometimes known as open enrollment, or sometimes known as fall enrollment, the time of incessant Medicare commercials, sales pitches, and stacks of mail. During this time, people can make changes to their Medicare Advantage and Part D coverage. They cannot generally make changes to their Parts A or B coverage, and they might not necessarily be able to make changes to other types of coverage. Employer-based insurance, for example, might have different time periods when people can make changes. And as we'll discuss further momentarily, there's generally no right to pick up a Medigap policy during this time period. This annual enrollment period, which starts October 15th and runs till December 7th, is limited to Medicare Advantage and Part D choices. Note, if you're in one of these plans, and that plan is still offered next year, and you do nothing, you will automatically roll into that same plan in the next calendar year. Just wanted to quickly note that there is another enrollment period worth mentioning. This slide is included to flag the fact that some people, not everyone, have another bite at the apple at the beginning of the calendar year for the first 3 months. There is an enrollment period called the Medicare Advantage Open Enrollment Period. If you begin the year, January 1st, enrolled in a Medicare Advantage plan, then you can change to another Medicare Advantage plan or disenroll and go back to traditional Medicare and pick up a standalone Part D plan. This is not available for people who are in traditional Medicare and have standalone Part D prescription plans. Which brings me to a general point I would like to make, that choice of coverage in Medicare, the options that people have, are unequal. It must be said that there is not free movement between the different types of coverage options in Medicare. They are not equally available between traditional Medicare and Medicare Advantage. There are many factors pushing people towards enrollment in Medicare Advantage, including attractive extra benefits that Medicare Advantage plans provide with extra money that they get from the federal government, massive advertising budgets and agent and broker commissions that pay a lot more for Medicare Advantage enrollments than they do for Part D or Medigap enrollments. And in many ways, enrolling in Medicare Advantage is a one-way street. And while you can change to other Medicare Advantage plans, and while you can return to traditional Medicare on an annual basis, most people will not be able to later pick up a Medigap policy because it is either unavailable or unaffordable. Note that some people's choice is made for them. Some retiree or union coverage exclusively offer Medicare Advantage as retiree coverage. Those people, if they wish to have any type of retiree coverage, must enroll in a Medicare Advantage plan. Not only are there unequal choices in the Medicare program, but the entire Medicare Advantage and Part D system is set up with the assumption that people act in their own best interest, do extensive research about their options, and choose accordingly. But this simply does not happen. Every year, in addition to deciding whether or not they're going to continue to participate, private plan insurance companies change their benefits and cost sharing within permissible parameters. And there's no guarantee that a plan that works fine for you now will continue to do so next year. This system assumes that everyone will actively compare their plan choices and make optimal decisions for themselves. But as noted in this KFF study linked in the slide here, nearly 7 in 10 Medicare beneficiaries do not compare their own source of Medicare coverage with other Medicare coverage options offered in their area. Most people, if they go through the exercise of picking a plan once, say, that's it. I'm not going to do that again. I'm done. And stick with what they have and let it roll over into the next year, year after year. This is understandable, but it is not advisable. In a few minutes, I'm going to talk about Medicare Advantage versus traditional Medicare, and then Melanie will get into more practical advice for people navigating all of this. But now I want to shift gears a minute because of the volume of questions we received about Medigaps and Part D. We will briefly go into more detail about both before moving on to the next section. So starting with Medigaps. For those also known as Medicare supplemental insurance policies. For those who wish to stay in traditional original Medicare and not enrolled in Medicare Advantage plan, there are plans that are designed to fill in some of the gap in costs. Medigap plans are standardized by letter, so all plans offered under one letter, you know exactly what you're going to get. So you can actually compare by monthly premium alone, unlike what we advise to do with Medicare Advantage and Part D plans. I want to underscore the point that coverage choices in Medicare are not equal. Unfortunately, unlike the ability to pick up a Medicare Advantage or Part D plan every year during the annual election period, rights to purchase a Medigap policy are much more limited. The Affordable Care Act's prohibition on companies discriminating against people with pre-existing conditions does not apply to Medigap plans. A quick side note, there's currently a debate about to what extent some new anti-discrimination rules apply to certain Medigap carriers and how it will be enforced. If you want to learn more about this, the Commonwealth Fund has a great blog that discusses this issue. That remains to be seen. Under federal law, companies do not have to sell to anyone under age 65 and are only required to sell to people during the 6 months, the first 6 months that they have both Parts A and B of Medicare, as well as certain triggering events. While most of the Medicare program is governed by federal law, there are a few notable exceptions to this. Eligibility for Medicaid and Medicare savings programs, as Melanie will discuss, can be determined by the state, so eligibility will vary depending upon where you live. And Medigap rights. States have the right to expand access to Medigap plans. Many states have added extra rights to purchase Medigap plans, including some states that require plans to sell to people under 65, but only 4 states concentrated in the New England area, Connecticut, Massachusetts, Maine, and New York, which I know is not part of New England, allow at least an annual opportunity to pick up a plan. So although Medicare is a federal program, local and accurate information really matters. Shifting to Part D, access to prescription drugs is often critical for individuals with chronic conditions. We're going to talk a little bit about Part D coverage. Later on, we're going to get to the new out-of-pocket cap. Note that Part B of Medicare covers certain drugs that are not usually self-administered, and Part A covers drugs in certain care settings like hospitals and skilled nursing facilities. The Part D prescription drug benefit is only available through private plans, standalone prescription drug plans, or Medicare Advantage plans that offer prescription drug coverage. They have to follow certain rules, but otherwise have discretion to establish their own formularies, lists of covered drugs, and can place restrictions on accessing those drugs. And while Medicare drug plans can add new drugs to their formularies during the year to reflect new approvals, plans are not required to cover every new drug that comes onto the market. Plans include both brand name and generic drugs in their formulary and can place drugs on different cost-sharing tiers. In other words, they can make some drugs less expensive for folks and some drugs more expensive. Part D plans are generally required to cover at least 2 drugs per category and class, but can choose which ones they cover. But they have to cover all or substantially all drugs in 6 protected classes that are listed here in the slide. The Medicare program does, in theory, do a review of plan rules and coverage to make sure that the way that the benefits are set up don't discriminate against people based upon their health condition. Plans do have the flexibility to change the drugs on their formulary during the course of the year, as long as such change is approved by the Medicare program. Note that there is a process to get drugs that are not covered on the formulary covered by your Part D plan. This is known as the exceptions process. Later on, Melanie's going to provide some practical tips for requesting an exception. Now, you move on to the trade-offs between Medicare Advantage and Part D. Now, we're going to focus on the disadvantages of Medicare Advantage enrollment. We do this not because we're generally negative or mean people, but because you are far more likely to hear about all of the advantages in all of the plan advertising, TV, radio, print, promotional events, agent and broker presentations, in which these disadvantages are either downplayed or omitted entirely. It might not matter for Medicare Advantage enrollees who don't need to use health services, but for individuals with chronic conditions, these factors are critical to consider. And note that the concept of choice is promoted and celebrated when people are shopping for plans or when searching for a Medicare Advantage plan. But the notion of choice turns out to be much more limited when you're actually enrolled in a plan, particularly when it comes to who you get care from and what care you get. This slide, comes to us courtesy of the Kaiser Family Foundation, and it outlines some of the potential advantages and potential disadvantages of enrolling in a Medicare Advantage plan. Some of the advantages include it is really the path of least resistance. You don't need to pick up a separate Part D plan or a Medigap plan. You can, in theory, get all of your care through a Medicare Advantage plan. Medicare Advantage plans tend to have lower premiums or $0 premiums due to their use of extra rebate dollars that they use to essentially buy down people's cost sharing. Medicare Advantage plans often have extra or supplemental benefits, which is a huge draw for individuals. Often dental, vision, hearing are the big ones. Different types and additional types of supplemental benefits have been added in recent years, but none of the extra benefits are standardized and they do vary considerably. And unlike traditional Medicare without some other kind of supplemental coverage, Medicare Advantage plans are required to cap people's out-of-pocket expenses, but they have a certain bit of discretion on where they set those caps. In 2025, the rules allow the cap for essentially HMOs that use a network of providers to cap expenses as high as $9,350. Often it's lower than that. And for PPOs, which allow people to go in network but also out of network, the combined out-of-pocket cap can be as high as $14,000, but likely would be less than that. As far as disadvantages, we're going to talk a little bit more about the first and third bullets of provider networks and prior authorization. In addition, some costs can be higher than in traditional Medicare, and as we'll touch on in a few slides, not necessarily lower costs all around. When it comes to Part D coverage and Medicare Advantage, it's really take it or leave it with a given plan. There's no cafeteria option to pick and choose what Part D coverage you like to combine with what other Medicare Advantage coverage you might want. And as discussed regarding Medigaps, there is a limited ability to return to traditional Medicare. In traditional Medicare, you can see any provider in the country that is willing to take you. Medicare Advantage plans, however, as a cost-saving measure, can generally limit who you see as far as providers. There's a difference between generally HMOs and PPOs. HMOs usually don't cover out-of-network coverage except for emergency and urgent situations. PPOs usually allow out-of-network coverage, but at a higher cost-sharing level. Some Medicare Advantage plans, including HMOs, do have more open networks and allow you to see providers in other areas, but that can vary considerably. For individuals with chronic conditions, seeing the right providers, including specialists, is often critical for maintaining health or slowing deterioration. More and more providers, health systems, are walking away from Medicare Advantage plans because of frustrations with wasted time and denied care due to prior authorization and lower reimbursement rates. Just because your key provider or providers contract with your plan now is no guarantee that it will continue to be so. And just because you are in a PPO is no guarantee that a provider will see you out of that network. Beware of ghost networks, providers listed in a plan directory but who don't actually contract with the plan, who aren't taking new patients, particularly pronounced when it comes to mental health services. Prior authorization is a process that plans can use to try to make sure that the care provided is medically necessary, not unnecessary, and not wasteful. It is meant to weed out unneeded care. The flip side is that prior authorization can also weed out care that is medically necessary. And while traditional Medicare has very limited instances in which prior authorization applies, nearly all Medicare Advantage plans use it extensively, particularly for higher cost items and services. A recent KFF study, also linked here in the slide, quantifies how often it is used, and a Health and Human Services Office of Inspector General report, also linked here in the slide, tried to quantify how often it is used inappropriately. Now, when it comes to people who contact our organization, they usually do so when things are going wrong. But in our experience, borne out by independent research, it has gotten worse in recent years, even with efforts by the Medicare program to try to restrict inappropriate plan activities. In short, prior authorization can be a major barrier to care, particularly for those with chronic conditions. One takeaway is that if you are in a Medicare Advantage plan and have care denied that you believe should be covered, fight it and appeal if you are able to. Few people appeal, but when they do, many are successful. Now, if you are in a Medicare Advantage plan or choose to be in one, it might work out just fine for you. But because there's very little counter-programming to the avalanche of Medicare Advantage advertising and industry lobbying, I'd like to make a final overall point. It is worth mentioning that the insurance industry is trying very hard to convince not only the public, but policymakers that Medicare Advantage plans are inherently better for beneficiaries and outperforms traditional Medicare. Looking at objective independent research, however, this is simply not the case. It's not the case with respect to health outcomes. In fact, it's decidedly mixed. Medicare Advantage performs better in some ways, traditional Medicare performs better in others. And it is not at lower cost for beneficiaries, particularly not for the federal government. There is overwhelming evidence that Medicare Advantage plans are wastefully overpaid by the federal government. Topic for another time. But when it comes to MA enrollees themselves, it's not necessarily a better deal for them cost-wise. It's pretty much a wash, but some studies show that they even pay more when they are in Medicare Advantage plans. Now I am going to turn it over to Melanie, who is going to provide some practical advice about making coverage choices, and then move on to discussing various types of assistance that is available. Melanie, take it away.
Thanks, David. Hi, everyone. So as you know, as David just explained, we're coming up on the annual enrollment period or annual election period for 2025, where you can choose to make a change to your Medicare that will go into effect on January 1st. One of the tools that you can use to compare plan choices is the Medicare Plan Finder on the Medicare.gov website. The Plan Finder allows you to compare information on all standalone prescription drug plans and Medicare Advantage plans available where you live. And the tool has a lot of information on drug coverage offered by each plan, including which medications are covered, an estimate of the out-of-pocket costs for each medication you take, the ability to compare different plans and costs broken down by each medication, and ability to compare costs at different pharmacies, and information on any drug utilization restrictions in the plans you're considering that David explained you may encounter, such as step therapy, quantity limits, and prior authorization. The Plan Finder also has information on supplemental benefits offered by Medicare Advantage plans, but it's important to review the specific coverage of any plan you're considering. For example, if you're interested in dental coverage and are considering a Medicare Advantage plan because you want that dental coverage, make sure you review exactly what's actually covered in a given plan before you make any decisions. The Plan Finder is a great tool, but some of this information can be very easy to miss and sometimes hard to understand. Fortunately, there's a program that can provide expert, unbiased assistance at navigating not just the Plan Finder, but any questions you have around your Medicare benefits or enrollment decisions. And this program is called the State Health Insurance Assistance Program, or SHIP. I know there are many SHIP counselors and SMP counselors and MIPA counselors on the call today. And if you go to shiphelp.org, you can find the local contact information for the SHIP where you live. This will connect you with a trained counselor in your local community who can provide assistance with walking you through the Plan Finder and any enrollment questions you have, and can assist you with enrolling in a new plan if you choose to do so. These counselors do not receive any commission for their services. They receive funding from the federal government and sometimes state governments and other sources to help Medicare beneficiaries navigate through what can be a confusing process. So it's a service available that I think everyone should take advantage of. You can also call 1-800-Medicare to make a plan change or discuss plan options. This can be an option, especially when SHIP counselors are at capacity to take appointments, which often happens during the very busy annual enrollment period. The representatives at 1-800-Medicare can also help with comparing plan options and enrolling in a new plan if you choose to do so. And it's important to remember never to shop by premium alone, since the monthly premium is only one component of what you pay for your healthcare. A zero premium plan may have significantly higher out-of-pocket costs than a plan with a higher monthly premium, so it's important to consider total out-of-pocket costs and coverage for prescription drugs, as well as for health benefits you're considering if you're considering a Medicare Advantage plan. To drive this point home about how many variables there are to consider, just as David talked about, this is a summary of the many factors there are to compare when you're shopping between standalone Part D plans or Medicare Advantage plans borrowed from KFF. So there are a lot more than premiums to consider. There's deductibles for drug plans, which is the amount you pay out of pocket before your benefits kick in. Medicare Advantage plans can also have a separate deductible for the medical benefits offered under their plan. So it's important to review that when you're trying to figure out your out-of-pocket costs. You also want to take a look at the quality ratings or star ratings for plans you're considering. Plans are rated every year by CMS on a scale of 0 to 5 stars, and the score is made up of a number of factors, including how satisfied beneficiaries are with the care they've received, how often complaints or grievances have been filed against the plan, and other factors. And if this list looks overwhelming, again, remember that SHIP counselors can walk you through this comparison between plans and all the different factors, so you don't have to go it alone in navigating all these different variables. Many of the cost aspects of comparison with regard to your prescription costs will be much easier to compare in the Plan Finder, and that will include quality rating information as well, and much of these other details, so you can get closer to an apples to apples comparison of all the different options. David mentioned the many different types of other coverage that coordinate with Medicare and can often provide supplemental coverage in coordination with Medicare. We want to emphasize that if you have certain types of coverage, you want to carefully review that coverage with your benefits administrator and make sure you understand how enrolling in a Medicare Advantage or a Part D plan will affect your benefits. For example, if you have a retiree health plan that provides prescription coverage, ask your benefits administrator whether enrolling in Medicare prescription drug coverage, whether through a standalone PDP or Medicare Advantage, would cause you to lose your retiree health benefits or other connected benefits that you have as a retiree besides your health benefits, particularly if those benefits cover other family members in addition to yourself. And I know that, there are folks who are enrolled in Medicare Advantage plans through their employer, and these, of course, are can be connected to your benefits as well, if you have that specific Medicare Advantage plan through your employer, as David mentioned. So you definitely want to be aware of that before you make any coverage decisions and changes. So the bottom line is to talk to your benefits administrator, to discuss how your other coverage affects your Medicare, so you know what impact it will have if you make changes. It's important to look out for the annual notice of change, or ANOC, that you should receive in the mail from your current plan each fall. This should have arrived to you already if you're on Medicare, as they are sent out by September 30th each year. Typically, plans don't mail everything out anymore. They usually just tell you where you can find the information online if you've opted to receive plan notices electronically. So you may only receive an emailed copy of the notice, and more these, the ANOC, along with all the attachments that it refers to, are increasingly only available online unless you specifically contact your plan and request a hard copy, especially for things like the drug formulary and any changes there, which the drug formulary is a list of drugs that are covered on your plan. So the ANOC specifies exactly what's changing in your current plan from one year to the next, including network changes, premium changes, benefit changes, and drug formulary changes. And if you don't make a new selection during the annual enrollment period, you will be automatically renewed in your current plan as long as that plan is still being offered next year. I noticed some folks in the chat mentioning that that doesn't apply to everybody. It's important to review these changes and understand how it will affect you. So in addition to plan changes, folks who are enrolled in plans that are terminating or not renewing or consolidating will receive notices from their plan about how this will affect their enrollment if they do nothing. In some cases, if your plan is going away, you're automatically going to be switched to a different plan, generally with that same carrier. And your current plan will notify you of this, usually in multiple ways. It might be a letter and a phone call, or an email and a phone call. This plan may or may not be the best option for you, this plan that you get automatically switched to. So if you're getting switched, you should talk to a SHIP counselor or to 1-800-Medicare to do a plan comparison. In other cases, let's say you're in a Medicare Advantage plan that's not renewing in 2025 and the plan carrier does not have a plan it can move you to. That often means you'll simply be back in original Medicare on January 1st if you do nothing. So you would still have medical coverage, but remember that this means you could end up without drug coverage, and you may also be unable to get a Medigap, as David talked about, depending on your state and the timing of it with your Medicare enrollment. So it's much better to be proactive and review your coverage options during the annual enrollment period so there aren't any surprises come January. There's a link here too that refers to all the different notices you may receive from your plan and the timeline of when they are sent. It includes notices sent to everyone, as well as notices sent to all Medicare beneficiaries, as well as notices that only some beneficiaries receive, such as notices about extra help, or notices about your plan not renewing or terminating. There are additional special enrollment periods for folks who are in these non-renewing or terminating plans that will allow them a certain period of time to change their plan after the annual enrollment period ends. This does allow some flexibility in case some beneficiaries miss those notices. However, as I mentioned, there could still be a gap in drug coverage if you don't make a timely selection, as not all of these special enrollment periods allow for retroactive coverage. Say you don't make a decision January 1st, you find out you're disenrolled from your Medicare Advantage plan, you may not be able to pick up, say, a standalone Part D plan until February 1st. So you might be without coverage for that month. So again, it's just really important to be proactive. Make sure you review any notices sent by your plan. And if you need to change plans because your plan is non-renewing or terminating, make sure to choose that plan during the annual enrollment period rather than waiting to see what happens. One of the most common questions people have about their Medicare coverage is whether they should go with traditional Medicare or Medicare Advantage. David just explained a lot of the differences between the two and considerations on the pros and cons, but you may still be asking yourself what's right for you. And the reality is there's no one size fits all answer for everyone. People often want the same coverage that their friend or neighbor or spouse has because they like it. But everyone has different life circumstances, healthcare needs, budgets, and preferences that weigh into these decisions. So what's right for you really depends on your personal situation and what your preferences and priorities are. We've come up with 10 questions you can ask yourself to help in making this determination. I'm not going to go through this whole list now, but these are questions you can ask yourself based on the information we've presented that can help you figure out which option is right for you. I do want to emphasize certain questions as we specifically consider Medicare coverage for people with Parkinson's and other chronic conditions. Generally, I want to emphasize the considerations and some of what David said around provider networks, stability and predictability, access to care, and potential restrictions on drugs and medical care. Remember that if you're in original Medicare, you can go to any provider or facility in the country that takes Medicare if they agree to see you, as David mentioned, whereas with a Medicare Advantage plan, you're restricted to a network of providers, and that network can change at any time. And if you are considering a Medicare Advantage plan, again, as David mentioned, you don't want to just go by the provider directory listed on the plan's website to determine if your providers are in network, as these networks often change and are not always updated timely, and the ghost networks and all of that. So call your providers and confirm if they are in network for any specific plan that you're considering. You'll want to think about this for not just your primary care, but any specialists, any facilities, or other providers that you see, including hospitals, if you have a neurologist, speech language pathologists, occupational therapists, mental health providers, and so forth. If you're considering a PPO, consider the difference in cost sharing that David mentioned for in-network versus out-of-network, and whether you can afford to pay out-of-network cost sharing, or if you're in an HMO, if you can pay all of the cost sharing if you decide to go out of network. And for drug coverage, consider any utilization restrictions on your medications, especially if you cannot take generics. I know this can be a major concern for folks who take expensive medications or who have chronic conditions. So let's talk about tips for navigating drug coverage a bit more. I want to emphasize some of the Part D exception options that David mentioned. So if you take a drug that is not covered on your plan, remember that as long as it's not excluded from coverage under Medicare, you can apply for what's called a formulary exception, essentially asking your plan to cover that medication, even though it's not on the plan's formulary. And this can often be successful. If you take a drug that has restrictions such as step therapy, prior authorization, or quantity limits, so step therapy is when you're required to try certain medications first before another medication will be covered that treats the same condition generally. That can create, if this is creating a barrier to how your provider has prescribed the medication, you can also apply for an exception to ask the plan to lift those restrictions. And if you must take a more expensive version of a medication for a clear medical reason, you can apply for a tiering exception, asking the plan to cover that drug at a lower tier. And remember, this isn't simply because the drug is too expensive. It has to be because you have to take a higher tier version of a drug versus a lower tier version of that type of drug due to side effects or another medical reason for being unable to take that lower tier drug. The most important piece of a successful exception request is a supporting statement from the prescriber explaining why the medication is necessary to treat your condition. And your prescriber would submit this exception request to the plan directly and would follow the plan's instructions. Generally, there's a form for the provider to fill out and submit. Sometimes it can be as simple as a phone call. It really depends on the plan and their specific process. And if you're denied the exception request, again, you can follow the instructions to appeal and work with your provider on that, or contact your SHIP for assistance with strengthening your case as much as possible for the next level of your appeal. It's also important as consumers of all the marketing that David mentioned that's targeted at you as a Medicare beneficiary to understand what Medicare agents and brokers are and are not allowed to do. I know we have many SMP counselors on the call today who are very well versed in this, and I'll mention your program in a moment. For example, Medicare brokers and agents cannot come to your home or call you or attempt to enroll in a plan unless you've given your express permission in advance. They cannot engage in marketing activities in a healthcare setting or at an educational event. And in general, the principle to remember is that you would need to give your consent to a broker or agent for them to talk to you about enrolling in one of their plans. There's a full summary of these do's and don'ts that are linked here for reference. So in sum, it pays to compare your options. SHIP counselors are available to help you navigate what can be an overwhelming process. Remember that the purpose of health insurance is to provide you access to care when you need it. Make sure to review your coverage each year. Don't be pressured by aggressive marketing campaigns. And finally, contact the Senior Medicare Patrol Program in your state, or SMP, to report any suspected fraud, waste, or abuse, such as violations to Medicare marketing rules or concerns about a Medicare summary notice or an explanation of benefits you received for services or items that you never got. Okay, with that, I'm going to talk about assistance programs that can help with the cost of prescription medications and how that works with Medicare. So this slide and the next one are courtesy of the PAN Foundation. They have this great summary of financial resources for prescription drugs. First, there are assistance programs offered directly through pharmaceutical companies to help with prescription drug costs. And Medicare beneficiaries are generally not eligible to apply for these programs due to federal rules. There are, however, there's a great program called Extra Help, which I think we mentioned earlier on. It's also sometimes called the Low Income Subsidy, or LIS, that can drastically reduce out-of-pocket drug costs for Medicare beneficiaries. And this program does have income and asset restrictions, but if you qualify, it will reduce all of your out-of-pocket prescription cost sharing, including reducing or eliminating your premium and deductible, and reducing or eliminating copays for covered drugs. You can apply for Extra Help through the Social Security Administration, but I'm going to offer some tips about how to apply for Extra Help in a moment. There are also a variety, could you go back to the previous slide for just a moment? There are also a variety of assistance programs through charitable foundations, which have different rules and requirements, and some are disease or condition specific, and some have income and asset restrictions as well. The PAN Foundation website linked here has a plethora of information about different foundation assistance programs, and it also has an app called Fund Finder. The link is on this slide as well, that you can use to search for financial assistance from over 200 programs, depending on your circumstances and health conditions, or to sign up for alerts if there's no assistance currently available. Okay. There are also state pharmaceutical assistance programs, or SPAPs, which are programs designed to essentially wrap around Medicare coverage to assist with the cost sharing that Medicare does not cover. These programs have different rules in every state, and not every state has these programs. And there are also AIDS drug assistance programs for people with limited insurance and income to help them afford their HIV/AIDS medications. Finally, there are the Medicare Savings Programs, or MSPs, which I could talk about all day. These programs help Medicare beneficiaries with the medical portion of their cost sharing under A and B, including the Part B premium. And depending on the level, it can also cover deductibles and coinsurance for Part A and B covered services. The reason this program is on a prescription assistance slide is because if you are eligible for the Medicare Savings Program, it will automatically qualify you and enroll you in the Extra Help program. And the great thing about this is that the eligibility for MSP is sometimes higher in terms of the income limits and the asset limits than for Extra Help. So I highly recommend exploring your eligibility for MSP first before you apply for Extra Help. So how do you do this? One of the ways to do this is to contact your state SHIP and ask to be screened for the Medicare Savings Program. Most states use the federal income and asset guidelines, but some states have higher income and asset limits. So check with your SHIP to see if you qualify. There are some types of income and resources that are not counted in full, but this varies by state. So a SHIP counselor can give you a proper screening to see if you qualify in your state. And I should just say also you can contact your state Medicaid agency as well to apply for this program, because again, there are, of course, capacity issues with the SHIP program. So again, if you qualify for MSP, it will auto-enroll you in the Extra Help program, and this will save you money on both your medical and prescription drug out-of-pocket costs. And you can enroll in MSP whether you are in traditional Medicare or Medicare Advantage. This is a summary of the benefits of the Extra Help program. It eliminates the Part D deductible entirely, which can be up to $590 in 2025. It also significantly reduces or sometimes entirely eliminates the premiums for the plan and the copays for covered drugs. Remember, these are the copays for covered drugs, so you still need to make sure that you review your coverage every year, even if you have Extra Help. For example, folks who have Medicaid coverage and live in nursing homes who are receiving Medicaid funded home and community-based services will have zero copays for covered drugs. People with MSP and Medicare will have very low copays, no more than $4.90 for a 30-day supply of a generic drug that's covered, or $12.15 for other covered drugs for a 30-day supply in 2025. Extra Help also entitles beneficiaries to additional flexibilities around changing enrollment outside of AEP, which some folks know is changing a little bit next year, and can the Extra Help program can also provide immediate drug coverage through a program called LINet if for some reason you end up without a Part D plan. So again, here, these are things that, that a SHIP counselor can help with. You can also apply for Extra Help through Social Security. Okay, and finally, a lot of people ask about these prescription drug discount cards and programs like GoodRx and Cost Plus Drugs that you may have heard of. These programs all operate a little differently. Some have a card you show at the pharmacy counter, and others are completely online through mail order. There are two important things to remember for Medicare beneficiaries about these kind of discount programs. One is that you can choose to use these, or you can choose to use your Part D benefits. I talked to a Medicare beneficiary recently who thought that meant she couldn't be enrolled in Part D and use this, and that's not the case. It's that you can use one or the other when you're at the pharmacy paying for your medication. And the other is that out-of-pocket costs paid using a discount program do not count towards your maximum out-of-pocket threshold for Medicare. So you may end up paying more out-of-pocket in total if you use both a discount program and Part D. And with that, I am going to turn it back over to David for 2025 updates.
Right. Thank you, Melanie. So now we're going to turn to take a quick look at some of the changes to the Medicare rules and Medicare plans that'll be going into effect in the new year. This slide is just a quick overview of some of those changes. We're going to talk more about the first two bullets, the landscape of Medicare Advantage and Part D plans, and the new Part D changes, namely the $2,000 out-of-pocket cap and the Medicare prescription payment program next. I also want to mention here, but won't go into more detail about a couple of other changes. Starting next year, Medicare Advantage plans will have to be more accountable about the extra or supplemental benefits they offer. This includes a requirement that they send out a mid-year notice to enrollees about unused extra benefits that might still be available to them. Another change has to do with special enrollment period rights to change Part D and Medicare Advantage plans for individuals who are low income. Note that the new rules link on this slide goes to a Medicare fact sheet that talks about them. We also linked to a publication by our friends at Justice and Aging that explains these special enrollment periods and other rules. So with respect to the 2025 Medicare Advantage and Part D plan offerings, Despite Medicare Advantage plans getting significantly overpaid, complaints that they didn't get as much of a raise as they had hoped for 2025, complaints that people are using more services than expected, even getting through onerous prior authorization requirements, and new regulations they have to comply with that generally hold them more accountable and improve consumer protections. Both Medicare Advantage plans have signaled that they will need to pull back on some of their benefits. Both Medicare Advantage and Part D plans have to implement the Inflation Reduction Act changes that we're about to talk about, including the out-of-pocket cap. And because of these factors, some plans have warned that they're going to have to change their benefits. The 2025 plan information was released last week, and folks are still poring over it, but there are a few threads or generalizations we can make at this time. There was a good quote or analysis by Stat News that pretty much said, with respect to Medicare Advantage plans for next year, remarkably stable broadly, but rife with changes under the surface. If you are in one of these plans, it's critical to see how your particular plan is changing. As Melanie noted, pay particular attention to the annual notice of change. Among other things, Medicare Advantage plans tend to use their considerable overpayments to reduce premiums and cost sharing for Part D coverage. Stat News reports that with 2025 Medicare Advantage plan benefits, we are likely to see increases in Part D deductibles and also likely to see increases in the maximum out-of-pocket amounts. Melanie talked about what happens when some plans are terminating. Also be aware that for those who are in a PPO that is ending and who like the flexibility to see out-of-network providers might not automatically be moved to an HMO offered by the same plan sponsor, but will likely be heavily marketed or pressured to do so. With respect to Part D plans, the Medicare program issued a release a couple of weeks ago stating that the average total premium is expected to decrease in 2025. However, a subsequent KFF report issued a few days ago says that looking at premium changes for a few of the more popular plans shows more of a mixed picture across plans. And they provide a specific example with California plans and how some of those premiums are going up, despite a demonstration that the Medicare program instituted that is meant to keep premiums down. All of this is to say that it is critical to look at what is happening with your plan and to shop around. Changes are likely to be bigger this year than in past years. Now, let's turn to the source of the biggest change in prescription drug coverage in Medicare since Part D was created, the landmark Inflation Reduction Act of 2022, or the IRA. The IRA is responsible for a number of changes to Medicare prescription drug policy, including the ability of the Secretary of Health and Human Services to negotiate the prices for certain high-cost Medicare drugs, checks on the annual increase in the cost of drugs and premiums, and changes already in effect, such as a monthly limitation on insulin copays, free vaccines, and expanded access to the low-income subsidy. But perhaps most significantly for consumers is the out-of-pocket cap on Part D drug costs that's actually in effect this year, but will lower to $2,000 in January. As a result of the IRA, this is what the standard Part D benefit looks like as of January 1st, 2025. Among other things, it has streamlined and simplified the Part D benefit. After years of having a donut hole that dropped people for coverage altogether, and then if they were needed prescription drug coverage, would pick up again at another level. The donut hole was gradually changed due to other legislation, but there then remained a coverage gap where cost sharing for individuals could vary. Now the benefit is much more straightforward. This is it. There's a deductible. Once you meet the deductible, you enter the coverage phase where you are generally responsible for 25% of the costs of your drugs until a $2,000 out-of-pocket cap is reached. Then there are no out-of-pocket costs for covered drugs. This out-of-pocket cap will be hugely impactful for people with high drug costs. It brings Part D in line with much other insurance that caps out-of-pocket caps. A critical question that a lot of people are asking is, well, what counts? The out-of-pocket cap does include this deductible. It does not include premiums, monthly premiums that you pay, and it does not include drugs that are not covered by your Part D plan. Remember, though, as Melanie mentioned, there is an exceptions process to try to have an uncovered drug covered by your plan if certain criteria are met. Now, this slide reflects the basic benefit in 2025. Note that most plans, at least this year and in previous years, are what are known as alternative or enhanced plans, meaning that they provide at least benefits at least as good as this, but often better. They can lower that deductible amount, they can lower the cost sharing amount, and sometimes even cover drugs that are not covered under Part D. So again, nuance matters. It pays to look closely at what the different coverage options are and how your particular plan might be changing. Along with the out-of-pocket cap, the IRA provides for another consumer protection that allows people to spread the costs of their drugs over the course of the calendar year. But it might not be the best option for everyone, though. People would be better off if they qualify for that extra help or low-income subsidy. That should be the first thing you take a look at if you are considering whether or not to participate in this Medicare prescription payment program, or MPPP or MP3 or C3PO. It had different acronyms at different points. Now, as people are just calling it the Medicare Prescription Payment Program. This program is voluntary. It is not automatic. If you are interested in it, you need to sign up through your Part D or Medicare Advantage plan. You can do that now, effective January 1st, or you can do that any time of the year, starting in January. If you enroll in this program, you will receive a monthly bill that can and very likely will change in amount every month. Before you sign up for this, we advise, and the Medicare program itself is advising people to take a hard look to see if it will help you. Note that it does not save you money or lower your drug costs. It just changes when you are responsible for paying expenses that you owe. It is most likely to be of benefit to you if you have high drug costs early in the year, but it's less likely to help you if your yearly drug costs are low, or your drug costs are the same every month, or you sign up late in the calendar year. The Medicare Plan Finder should have a tool that will help you assess this and try to anticipate costs. Also, take a look at the links that are included in this slide, which include some examples that show some of the trade-offs. Take a look at the second example here. For example, if you have drug expenses of $80 per month, you will pay lower costs at the outset, but those costs are merely deferred, not eliminated, so that you have to catch up at the end of the calendar year with much higher costs, way above $80 by the time that the calendar year runs out. This next slide is another slide we borrowed from the PAN Foundation that does a good job of providing an overview of both the out-of-pocket cap and the Medicare prescription payment program and the differences between the two. We'll leave that there for you to read. This next slide has a number of additional resources, including with respect to the Part D changes we just covered. I would now like to turn it over to Maria and Mason from the Michael J. Fox Foundation for a discussion of all of this in the context of individuals with Parkinson's and other chronic conditions. Mason and Maria.
Thank you, David. We really appreciate that. And hello again, everyone. I know David and Melanie have done a real deep dive into some of the changes that are coming. And we want to sort of highlight the areas that are going to be important for people living with Parkinson's disease, as well as other chronic conditions. And while we talk about this in the context of Parkinson's, much of what we cover will be applicable to people living with other chronic conditions as well. So I want to quickly reintroduce Dr. Maria De Leon. Again, she is a fellowship-trained movement disorder specialist, which is a type of neurologist with additional training in movement disorders like Parkinson's disease. Like many of you, she is also someone who lives with Parkinson's disease and receives health care through Medicare. Maria, thank you again for your participation. I would like for you to share what you think are the key factors to consider for people in our community while they're enrolling in Medicare this year.
Thank you, Mason, and thank you, Melanie and David, for that quick rundown and highlights of that very complex Medicare issue and how are important nuances to consider in making or selecting the new Medicare. And as a patient, I know exactly how difficult it is. So I want to consider or talk about four main factors that people with Parkinson's disease and other chronic conditions may want to focus attention to consider what type of plan would be best for them. As I said, many people live in Medicare, as Mason and others have said, 90%, and many of you also have fixed income. So cost is a huge important factor in this, not only because many of us also have comorbidities and other diseases, but also because the disease is progressive. And so the cost of living with a chronic illness like Parkinson's disease can be overwhelming and can be a very important factor to take into account. The other thing is because it's a complex disease, Parkinson's, we need many physicians and health staff that would help us. So this is important, and also trying to locate the right plan for us that the healthcare providers we need or see routinely are covered. Many can also be out of network and also away from our local area, so things to consider. The other thing, again, because this is a progressive disease, many of us have to take multiple medications, and that can be overwhelming, and trying to find the right coverage that will cover most of our medications. I've yet to find one that covers everything, but I think the most important thing to consider, again, is the cost and the main important medications. So look around, shop, and see what works best for you. And finally, that again, this disease is progressive and can be unpredictable at times, but take into account when selecting a plan what stage you're in. Are you in early stage? So you probably need a lot less care overall, less cost, less medications, versus being somebody that's end stage or late, three plus stage. So those are the things that I would take into account: the cost of healthcare providers' prescription and the progression and predictability. Thank you so much, Mason.
Awesome. Thank you, Maria. And I want to dive in a little bit deeper into sort of each of those topics because I think they're really important, particularly around costs. Because I know David and Melanie shared a lot of information about how the new $2,000 out-of-pocket cap for prescription drug coverage and the option to smooth costs over a plan year by enrolling in the Medicare prescription payment plan could be really helpful. So Maria, could you explain a little bit more about why these changes will be important to people living with Parkinson's disease and other chronic conditions?
Yes, thank you, Mason. Well, as I said earlier, living with a chronic illness can be very costly, especially when you're dealing with a progressive disease. So things are going to change. Whether they're going to change rapidly or not depends, again, on your age and other factors and stage you're in. So it's important to compare your health plans in this regard, because you may need a lot more, not only ancillary care, but other physicians. The primary physician that you have to have is either a neurologist and or a movement disorder specialist. So that make sure that that is covered along with your primary care physician. So we need to make sure that those are included. And as I said earlier, and many have said, that a lot of these medications have higher premiums, although there's going to be now a cap, and you're going to have a $2,000 out-of-pocket cap, which will help a lot in a lot of instances, but may not cover all the medications you need. So it's important to discuss your Medicare prescription payment plan and what type to enroll, and ask questions. What if something were to change, or if I were to, be on a higher tier, or so on. So these are the important things to take into consideration, I believe, when looking at the cost of payment, and also what is the best Medicare plan for you. But you must enroll, and you have to actively participate and look and talk to someone and look at the tips that Melanie and David have given us earlier to help you.
Awesome. Thank you for that, Maria. So as you mentioned, Again, many people or many patients who rely on Parkinson's medications that may be super expensive. And so it's important for you to acknowledge this new $2,000 out-of-pocket cap for prescription drugs because they may reach that cap relatively quickly. Additionally, as you mentioned, they may benefit from enrolling in the prescription payment plan and be able to smooth those costs over a plan year. But this year is really important. It's really critical that folks review their options. And to David's point, nuance is important here. You need to select the plan that works best for you. And then I also heard you talk about sort of healthcare provider networks and why those are so important to folks living with Parkinson's disease. We have to look beyond just our, general healthcare provider or primary care provider, and even beyond just a neurologist, because it really takes a whole team to provide care for folks living with Parkinson's disease. And so I know you've mentioned some of those healthcare providers, but beyond primary healthcare providers and neurologists, what might be some other healthcare providers that folks living with Parkinson's disease are really going to be considering?
Yes, thank you, Miss. As you know, Parkinson's affects everyone from head to toe, and it is very complex disease, and it requires multiple specialists. I, as a Parkinson's patient, have a rheumatologist. Rather, sorry, I have lupus also, but I have pulmonologist, cardiologist, GI doctor, along with my neurologist. So you have multiple specialists to consider depending what symptoms you're having with your Parkinson's, sometimes urinary specialists and gynecologists and so on, but also many ancillary workers, as well as you mentioned earlier, physical therapy, occupational therapy, speech therapy, cognitive therapy. So all of those things, and also make sure that your labs are covered, because sometimes you're going to need, diagnostic treatments or follow-up treatments like bone scans and follow-up MRIs or blood work for vitamin deficiencies and so on. So you need to make sure that those labs where you would routinely do your work and the tests that the doctor may order are also covered in the plan and the network.
Awesome. I really appreciate you highlighting that it still comes down to each person's sort of Parkinson's journey, in which healthcare providers might be necessary to provide care for certain folks. And to David's point earlier, it's incredibly important for folks living with Parkinson's disease who access their health coverage through Medicare to make sure or have for certain that their healthcare providers are covered as part of their network. Be wary of those ghost network providers. And Maria, I know you're really passionate about patient access to prescription drugs, particularly for Parkinson's disease. And we know that it's going to be the primary concern of many patients during this Medicare open enrollment period. And so we know that some Medicare plans implement additional requirements, as Melanie mentioned, such as prior authorization or step therapy, maybe even quantity limits. And these can impede patients from accessing the prescription drugs that they and their healthcare providers believe will work best for them. And it is expected, not confirmed just yet, that health plans will impose more of these types of restrictions this year. So it's incredibly critical for folks to review how their Medicare Advantage or Medicare Part D plans cover their Parkinson's medications, as well as medications for other conditions, to make sure that they will be covered within the next year. I know you had a really important part that you wanted to highlight for folks in regards to prescription drug coverage.
Yes, I do. And before that, I forgot to mention, very important that also mental health providers are important parts, since many people with Parkinson's have cognitive and mental issues. So we cannot, overlook that. But one of my main concerns is that patients will be forced to rely only on generic versions of Parkinson's therapies that have been around for 50 years, rather than the prescriptions that they know or their healthcare providers know will make a bigger difference in how they manage their disease. So, as I said before, this is a very complex disease, and each person's individual journey is extremely different. So we have to make sure that we have the right medications available to each one as best we can to manage our condition. And only being able to access generics or only a portion of what we need can be detrimental to our care and to our quality of life. So it is important that we advocate and we talk to the networks that we're dealing with about, being able to get access to the things that we need, medications, patients and providers in being able to continue to manage and live the best life we can with our chronic illnesses, in this case, Parkinson's disease. Thank you.
And I think you bring up an important point that health plans may not be able to cover every single medication, so it's important to consider which ones are most important to you as you're planning your journey for the next year. But that sort of gets us into this conversation about Parkinson's disease progression and the predictability of Parkinson's versus making a plan selection for a full year. And so I was wondering if you could explain a little bit more for folks who are listening in that maybe are less familiar with Parkinson's disease, a little bit about Parkinson's disease progression. But really, how can people living with Parkinson's disease or other chronic conditions prepare to enroll in the plan that will meet their needs, given that it might be progressive?
Yes. Well, as you know, Parkinson's disease is a progressive movement disorder that affects the nervous system and is characterized by several symptoms. The four primary ones are tremors, stiffness, and difficulty with movements, rigidity, and problems with gait. This is due to deterioration of some of the chemicals and some of the neurons in the brain responsible for dopamine production, which is important in learning and movement. So therefore, also it can cause other non-motor movements and problems. Aside from the ones I just mentioned, you can have issues with autonomic dysfunction, blood pressure problems, fainting, sweating, mood disturbances. And so it is a very complex disease that requires management by multiple medications and multiple physicians and healthcare providers. Because the progression can usually, because it's a very slow disease, progressive, typical Parkinson's is over 15, 20 years, it's not going to advance very rapidly. But depending on your age and your stage, there may be some nuances where you may feel like you're progressing a little bit faster or may require some other ancillary care or perhaps hospitalization or advanced medications. So we have to keep that in mind and talk to our physicians about what stage we are, what the prognosis is, what are we looking for in the next year. So kind of give us a sense of, are we going to be staying on these medications, for a year or two, or, we're at that, point where we may be considering adding or changing things. And so we need to consider those things. So it may look different. So it's essential that people living with Parkinson's and their partners prioritize health plans to meet their individual needs, their out-of-pocket expenses, their location, because as we said, everybody's journey is completely different. Although there's a lot of similarities, we still need to see where we are, what we need, and we all tolerate medications differently. And that's why we have so many different needs for different types of formulations, because we don't all respond or tolerate the medications in the same manner. So gathering information and discussing enrollment options with your healthcare provider, first of all, as to your disease state and the outlook, and also projecting, are you still going to need you're going to be okay living at home, or are you going to need other assistive devices, or perhaps looking at, some rehab or nursing home or things like that they may come into play for your family and you. And also take into account your loved ones and caregivers, where the status are, and are they going to be able to provide the care and have the resources for those things that you may need. So again, talk to your providers about what is the best thing. If you have multiple doctors, what is the outlook? Are you going to continue to need them on a regular basis, or just, periodically? Because that can make a difference in the plans that you select.
Awesome. Thank you for that, Maria. And I really appreciate you highlighting the need to connect with your healthcare provider and then being an active participant in this conversation.
And also, one thing I forgot is that This is because of all this changes and nuances and everybody's individual journey, and not being able to get everything that we need highlighted. We need to advocate for ourselves and for our loved ones for greater access to medications and resources so that we may be able to control our symptoms and live better life, especially as Parkinson's increases with age. And we age, we also tend to have other comorbidities like diabetes and hypertension and so on, and even other diseases. So it is important that we keep those things in mind and talk to the healthcare providers and our congressmen about changes to help us navigate this disease better.
Awesome. Thank you for that, Maria. And yeah, I really agree in terms of advocacy and making sure folks are, taking the time to review the plans, speak with their healthcare providers, speak with SHIP counselors or other folks who can help them as they make these decisions. As you know, and we at the Fox Foundation, we advocate on behalf of policy to continually improve government programs like Medicare that make a difference in the lives of those who are living with Parkinson's disease as well as their loved ones. And we believe this out-of-pocket spending cap and the new option to pay drug costs via monthly payments will be game changers for affordability and access for folks who are living in our community. And we are seeking to maximize their impact. So we're going to drop a call to action in the chat for folks who are interested. And it's a simple form that you can fill out online that allows you to send a message to your representatives in Congress to request their support for a new bipartisan bill called the Increasing Medication Access for Seniors Act, or HR 8725. And the purpose of this bill is simple. If passed, it would require the government department responsible for implementing the Medicare Prescription Payment Plan, or the MP3 or C3PO, as David put it, which is HHS, the Department of Health and Human Services, to report to Congress about that program's success, as well as how they plan to improve it over time. Specifically, they'll be required to submit annual reports to Congress about the number of Medicare enrollees who have chosen to participate in that program, as well as outline how HHS is working to make it possible for patients to opt into this program when picking up their medications at the pharmacy. So you can look for a link in the chat related to that from Brenna. Thank you, Brenna. And if you're interested, you're more than welcome to take action alongside the Michael J. Fox Foundation. And for now, I know we have a few minutes left, but we want to quickly pivot to a question or two that came in prior to the webinar. So, Maria, I believe you have one of those for the panelists.
Yes, thank you, Mason. I think one of the questions we have, and I think these have been highlighted already, but I will ask again. Who can I reach out to help if I cannot schedule an appointment with the state health insurance assistant plan coordinator or counselor?
A great question. Thanks, Maria. As we mentioned, the SHIP program doesn't necessarily have enough capacity to serve every Medicare beneficiary, especially when you get deep into the annual enrollment period and they're getting maybe hundreds of calls. And I did see someone comment in the chat, in some places, all those open enrollment appointments are filled already in some places. So SHIPs actually do have a mechanism to notify CMS when they've reached capacity during open enrollment, and 1-800-Medicare usually would actually refer people to their local SHIP to get that one-on-one counseling. But at that point, when they find out they're at capacity, that will stop, and 1-800-Medicare will take those calls. And at that point, the SHIP will say, they'll let folks know that they can call 1-800-Medicare to get that one-on-one assistance. And they will have representatives available up until the last minute that you can call on the phone and talk through your options. One thing to keep in mind is don't wait until the end of the annual enrollment period. Don't wait until December 5th or 6th or 7th to call, or you may kind of have to rush into a decision or not have time to speak with someone and really be planful about it. So those are some thoughts. I don't know, David, if you had anything to add or.
Thanks, Melanie. Yeah, the SHIPs are the first place that we refer people to. But given the capacity limitations, folks at 1-800-Medicare are able to field questions and are supposed to be objective. Elder law attorneys sometimes are able to provide assistance Certain community groups are able to provide assistance. We know that there are some honest and decent agents and brokers that really do the best for their clients, but also be aware that there are financial incentives, and unfortunately, too many agents and brokers will follow their own pecuniary interests rather than your individual needs. We need more assistance available. One of the important dates coming up, we know, is December 7th is the last day for this enrollment period. November 5th is also a very important date coming up for everyone. So please vote. I'm not telling you how to vote, but please vote.
So I appreciate that. The second call to action today is to make sure that you vote.
Yes.
And I want to reinforce Melanie's comment about being proactive. You are an agent of change in the world, and the experience that you want to have with healthcare, and being as proactive as possible, getting as much information collected as possible, whether it be from online, your healthcare providers, folks like SHIP counselors. It's all critical to making that decision that's going to set you up for success in the next year.
Thank you so much. That was wonderful. If I may, I have another question that came in earlier. During the open enrollment period, can someone switch from the Medicare Advantage plan to traditional Medicare plan, with or without Medigap, or vice versa?
Yeah. So the annual election period, this period that starts on Tuesday, October 15th through December 7th, is specifically designed to allow people to make changes to their Medicare Advantage coverage or their Part D coverage. So one of the changes you can make is going from Medicare Advantage back to traditional Medicare, and you can pick up a Part D plan. So that's effective January 1st, and vice versa. You can enroll in Medicare Advantage. But just remember that this time period does not generally allow people to pick up a Medigap policy if they're not in a state that requires an annual opportunity or more frequently to do so, or if they find themselves in a situation where the company won't sell them a policy. So yes, in theory, you can change, get in and out of traditional Medicare and back to Medicare Advantage, but be aware that getting back to traditional Medicare and picking up a Medigap is more difficult. Hence the coverage choices are unequal, as stated earlier.
I just want to add to that, as far as enrolling back into traditional Medicare, sometimes people say, well, how do I do that? Well, the way that you do that is by enrolling in a standalone Part D plan that will automatically disenroll you from your Medicare Advantage plan and into traditional Medicare. Sometimes people think they have to disenroll first, and you don't want to do that because you could end up with a gap in coverage. So all you need to do if you do want to make a change to your coverage is enroll in a different plan, and that's going to automatically disenroll you from any prior coverage that you have.
That's wonderful information. Thank you so much.
Sorry, if I could jump in just for a moment. I just want to let people know it was posted in the chat, but we are going to stay on a little bit late. I know that Mason and Maria and David and Melanie all agreed that we can take an extra few minutes here to answer some of these sort of big picture questions that came in ahead of time. So thank you all for staying on with us.
Great. You want me to ask a couple more questions? Okay. Let's see. Another question that came in my Medicare Part D or Medicare Advantage plan won't cover costly medication. And I think this was covered already, but it's important to highlight. Will the money I spend on this still counts toward the $2,000 maximum out-of-pocket limit?
The short answer is no. If you need a drug that's not covered by your Part D plan, whether it's the standalone plan or Medicare Advantage plan that offers Part D coverage, and you need to pay for that drug, the amount you pay does not count towards that $2,000 out-of-pocket limit. That's why it's critical to be aware that you can appeal to have drugs covered. As Melanie mentioned earlier, if it's not within that universe of drugs that is not covered by Part D, and that includes certain weight loss, weight gain, generally over the counter, it's just a select number of drugs, then in theory, it's possible to have that drug covered. Even in some instances, if it's for an off-label indication. I think like 1 in 5 drugs in this country is prescribed for something that the FDA did not approve it to be used for, but because it is approved by the FDA and it's been found to be effective for other conditions, it can be covered. Now, there's certain type of evidence you need in order to have such off-label use covered, but when in doubt, appeal. Not enough people appeal, not enough people assert the rights that they have and fight back when they are told no. Do not accept no as an answer. People who work for plans will not like me saying that, but that's the last thing people need to deal with. If you are, trying to deal with a health condition that you have, a disease that might be progressing, the last thing you want to think about is what Medicare Advantage or Part D plan I have and what to do if the plan denies your coverage. But unfortunately, it's the system that we have, and the system requires you to fight if the plan won't give you what you want. Now, you might not always be successful, or you might not fit in within the rules that would allow you to get that drug covered, but it's worth a shot if you are able to do so.
Thank you for that.
Thank you, David.
Yeah, I was just going to highlight, David, you hit a really important point on making sure to continue to advocate for yourself. And Maria, I know this is something that you were looking into that applies to the plans that you're selecting this year, that many Parkinson's therapies may not be listed on formularies. And so to think proactively about what that means for your coverage options is something that's going to be critical for our community this year.
Yes, thank you, Mason. That's exactly what I was going to say. That unfortunately, not everything is covered, and you have to be proactive. But the one thing that I want to highlight also is that remember, a lot of us that have Parkinson's have days where we're brain fogged and can't think very well. So one, we don't want to wait to the last minute, as Melody said, and we will talk about which are the deadlines to keep in mind. But if you're not able to make all these decisions because you're not cognitively well or don't understand all the nuances, there are a lot of things to think about, using the resources David and Melanie have given us, but also may need to have a caregiver or a loved one to help us navigate and advocate for ourselves and help us make those decisions, because it can be very important and crucial in your ability to live better. And so the final question was, could you tell us some of the important deadlines for beneficiaries to keep in mind, so we can all highlight it in our calendars during the Medicare Open Enrollment Period?
So for the near term, December 7th is the last day that you can make a change or election or a Medicare Advantage plan or Part D plan effective for the calendar year next year. Now, you can make, in theory, multiple changes between now and then, and the last one that you make will be the one that sticks. Don't generally advise that. I think it would be more advisable to do your homework, review all your options. As Melanie said, don't wait until the last minute, but you have a little bit of breathing room. Take the time that you need to compare your coverage options. Take a look at how, if you're in a plan, how it's changing for next year. Shop around to see what other plans are, and then dig deeper. The Medicare Plan Finder will provide a certain surface level of information, but if you can narrow your choices down, take a look at that plan, try to get the evidence of coverage, take a look at the details, because oftentimes the details matter. Now, if you're in a Medicare Advantage plan, you do have another bite at the apple starting January 1st of next year. Do that first 3 months of the calendar year. It's not fair, mind you, because people in traditional Medicare with the Part D plan don't have a similar option. But again, it's the rules that we have. You have another opportunity to change Medicare Advantage plans at that time. And then if you find yourself in a situation where you are unable to get the care that you need through your plan, and you're outside of these enrollment periods, look at that list of special enrollment periods. In one of the earlier slides, there's a link to a document that outlines all of the different special enrollment periods. There are quite a few, and there are some that rely on exceptional circumstances, including continuity of care. And if you find yourself in desperate straits where you cannot get the care that you need from the plan, there's another possible opportunity to try to change plans if you can find a better one using a special enrollment period.
Thank you so much, David.
Yeah, I want to say thank you, David and Melanie and the entire CMA team on behalf of myself, Maria, and the Fox Foundation. Again, we were really excited to partner on this webinar to help direct our community to some resources and experts related to these topics. So I want a big thank you to the Center for Medicare Advocacy for partnering with us on this event.
Thank you for
Thank
partnering
you.
with us. It's much appreciated.
Thank you all. In fact, thank you to our fabulous presenters, Dr. De Leon, Mason, David, and Melanie. Thanks to the audience. This was the liveliest chat that I think I've ever seen on a center webinar. I love it. I am saving the chat, and I think that I can get copies of that out to folks, as well as the slides and the link to the video, which will all go out in follow-up emails. In addition, as noted earlier, you will also receive a link to the form to take action and join the Michael J. Fox Foundation in supporting the Increasing Medication Access for Seniors Act, HR 8725. Act today to improve access to necessary medications for our most vulnerable populations. And of course, please do stay tuned for information on upcoming presentations on our website and the Fox Foundation website. Thank you all once again, and I will conclude today's webinar at this time. Bye-bye, everybody.